I'm Paige Humble, so I'm the Chief Executive Officer of Lung Cancer Initiative. And if you're not familiar with our organization, our mission is to advance survivorship and provide support to those impacted by lung cancer through research, education, and access programs. So as I said before, we're so excited to be hosting our very first Screening Navigator Network meeting, where we hope to leverage the strengths from across our state and our region by uniting health systems and communities to increase lung cancer screening rates. And one takeaway we want you to have today, this is your network. It's designed to share best practices, to dive into topics of interest and need, and to build connections of support among each of you. The network is a part of a new Screening Saves initiative that we launched at the end of last year to increase screening rates here in North Carolina. So in addition to this network group here today, we've also been reaching out to primary care providers at places like the North Carolina Academy of Family Physicians Conference last winter, and also via survey to help get feedback, to help inform a messaging and awareness campaign. And we hope to begin piloting that this year as well. And we'll keep you all informed of that as it moves forward. So again, we're very excited about today. We need each and every one of you, and we hope that you'll engage and contribute to this group. We want you to support each other and use each other as a resource, because I don't think there's any question why any of us are here today. We want to detect lung cancer earlier. We want to save lives. And just think about what we could do if we're united in that effort, and we can really move the needle on lung cancer screening here in our community. So Jenni, I'll turn it back over to you.
Thank you, Paige. And yes, we want this to be whatever you want it to be, whatever is going to be helpful to you all. And so afterwards, if you want to send me feedback, we would love to hear how you'd like to see this group kind of get structured and organized. But we will today talk with Debbie and Hilary from the Duke screening program, lung cancer screening program. And I'm excited for them to share their work, because we had a smaller kind of focus group meeting in December, and they started sharing what they were doing. And I realized quickly that they have a lot of good best practices that I think we can all learn from and use. And so Debbie and Hilary, will you guys introduce yourselves real quick, please?
Sure. Yeah. So my name is Hilary Crittenden, and thank you for that introduction. I'm a nurse practitioner at Duke. I've been at Duke since I was a brand new nurse in 1993 and worked in several different areas at Duke's. And Debbie and my path have crossed over the decades that we've both been there. My entry to lung cancer screening came in 2014 when the program was first getting started. And that was an offshoot of the Duke thoracic surgery program. At that time, we did have a nurse practitioner who was seeing folks in the thoracic surgery clinic, but also starting to see the screening patients. And in 2014, we had 28 patients come through lung cancer screening. So as the word got out and screening became more of an established preventative practice, there became more need. And so actually in 2020, I guess it was 2022 now, I moved from thoracic surgery into lung cancer screening full time. And I see patients like Debbie primarily via telemedicine. So we do a lot of virtual care, but we also see patients both at Duke and Durham and at our Duke Raleigh location. So I go and see patients at Duke Raleigh usually twice a month. Those are folks that want to be seen in person, and the rest I see via telehealth. And that's it for me. I'll let Debbie introduce herself, but thank you for asking us to talk with you all today, and we're grateful to be part of this program.
Well, I'm Deb Semmel. I'm a nurse practitioner at Duke. I have been there, came just a little bit after Hilary back in '96. Have done a variety of things. As she said, we've passed each other. I started in the MICU, and we both were in pediatric bone marrow transplant way back in the day. And then I've done a couple other things. I started with the program initially back in 2017 while I was working in pulmonary, and then ended up back in oncology for a couple years and came back to do lung cancer screening with Hilary in 2022, end of 2022. I work primarily remote, as she does. We're pretty much 90% remote doing lung cancer screening. I see patients in person 2 days a week, which is for the folks who don't like telehealth, it works out beautifully for them. But otherwise, it's a really great place to be. We have a program that's growing, which is exciting and then challenging at the same time, as you all know. So excited to be here with you and also learn from you.
Thank you both so much. Why don't we go ahead and get started and just talk about how did you get the program at Duke started, and what are those initial first steps to get a lung cancer screening program started?
Well, the program started really pre-Debbie and I. Dr. Betty Tong is our medical director. She is a thoracic surgeon at Duke and had a significant interest in lung cancer screening. And she, with Dr. Jared Christensen, who is a thoracic radiologist, really spearheaded the program again back in 2014. And so that was before Debbie and my time. I was doing a little bit of screening as the numbers of patients grew, but that was truly seeing patients in a very busy, very demanding thoracic surgery clinic in the Duke Cancer Center, and then throwing in a screener here and there. When a screening patient would come through, I'd kind of change hats and go do that. But like Debbie said, it has grown and grown over the years. So we weren't really there to get the program started, but the Duke program has been around for a good 10 years now.
And what are some of the challenges that you faced when you got on board and just, not getting the program started, but when you joined, what were some of the challenges or things that you heard from Dr. Tong and getting the program going?
I would think when I came in, some of the biggest challenges were scheduling issues, because trying to figure out different templates and telehealth, making sure you schedule patients to be telehealth when they're telehealth and in person on the days you're there, which we have had some challenges with. That is that. And then honestly, just getting the word out to more and more providers is another thing that we have worked with throughout since I came in. That's been a bigger push for us to get it out to more of our internal med doctors, our family practice doctors, that they don't have to be managing all of this, that we're happy to take on that role. And then the final one that I can think of is our folks who don't have health care, the underserved population, trying to figure out how to meet those needs and to get those people the option and availability for scheduling. So that's something we continue to work on, that and the folks in the outer areas of our band that patients have to travel into Duke. That's one of the barriers to care. So those are some of the things that I've noticed and that we're still working on.
Yeah, I would second everything that Debbie just said. I think just the logistics. I found when I first started in the program, seeing the patients, whether it be in person or via telemedicine, was easy, and it was pleasant and an enjoyable experience. I mean, having come from a background of a lot of years in oncology and seeing people with lung cancer moving into a preventative health role was really refreshing and nice. But the logistics of, like Debbie said, making sure that patients were scheduled under the appropriate template. Our practice in seeing a new patient is really, they see 3 appointments. So they'll get referred to us by, say, their primary care provider, and all of a sudden they get a letter, or if they're in our Epic Duke My Chart, they'll see 3 appointments and wonder why is that. We do an initial telemedicine visit where we make sure they meet criteria for screening, briefly review medical and smoking history and any other potential risk factors they might have for lung cancer, and then go through that shared decision making. So explaining to them what the process involves, what the scan is like, what the follow-up is like, obviously the risks and benefits, and always giving them the opportunity to ask any questions that they might have. So that is always that first appointment. Then they get their scan, usually a day or two later, and then a follow-up appointment with Debbie or I to go over the results of the scan and make plans moving forward. So just getting that across and figuring out how to make sure that patients are scheduled appropriately. They don't see me on Tuesday and then get their scan 3 months later. That's been a little bit of a hurdle, although I think we're making some improvements there. And then, of course, like Debbie said, just getting the word out, how best to spread the word. Most of primary care providers and some of the pulmonologists that refer to us, when they learn that we have our own clinic, our own program, they don't have to do the shared decision making, which is huge, really time consuming. They don't have to order the scan. We're still working on that with them because they'll refer to us and then also order the scan. And so we have to say, nope, we're gonna cancel your order. We're gonna put in our order so that we get the results, and then reassure them that we'll make sure that they get all the follow-up information that they need. But yeah, I agree with all of what Debbie said.
Yeah, so that does seem like a lot for a patient. So can you tell me, what are the main questions that they have on that first phone call? And do they seem receptive? And do most patients then go on to get the scan?
Yeah, they do. I can count on one hand the number of patients that I've had over the past several years that have decided against getting their scan after we go over what to expect. What's been really interesting is that there are some patients that when we first see them, all they see is I have an appointment and they see lung cancer. And they think that they've been referred because somebody thinks they might have lung cancer. So I try, not with every patient, but if I have any sense of that, before I get too far into anything, I say, you are not being referred because anyone thinks, or because your primary care doctor thinks you have lung cancer. This is screening, like you get mammograms, like you get prostate cancer screening, colonoscopy. So I try to refer to it as something that is part of preventative medicine and just the things that we all do, or most of us do on a regular basis. Once we kind of get past that, this is who I am, this is who referred you, this is why they referred you, and potentially telling them not why they referred you, not because anybody thinks you have lung cancer. Usually goes pretty smoothly. So most people are pretty receptive from the start. Some people really don't have a sense of why they're there, what this involves. They see so many appointments and they think, I don't have time for this. But once we get to have that rapport with them, which we can establish pretty quickly, things go smoothly. And it's rare that I ever have a patient who says, I don't want to have my scan.
I agree with that. I only have had 3 patients since I've started that decided not to scan. And that was a personal choice. They really did not want to quit smoking, which was fine. I mean, that's their choice. But they also said they would never treat. And for them, they didn't feel a need to do it. They know that the door is open. If they change their mind and want to come back, all they had to do was reach back out and we'd be happy to get them in. But yeah, most want to do it. Most are glad to see the results and know that they're cancer-free.
That's great. And do most of your referrals come from primary care? I know you mentioned pulmonology as well. But where do they come from? And are they mostly Duke providers?
I remember correctly, Hilary, it's mainly Duke providers. We do have some self-referred patients, but the bulk are going to be family practice internal med. We do have some pulmonary folks who will refer in. Most of the pulmonologists, though, tend to follow their own. But from what I remember and from what I can see, I was looking at some of the stuff, information we'd gotten at our last meeting. It's mainly the primary care and family practice folks who are referring.
And Duke is trying to, as a program, I know Dr. Tong has been in discussions with some of the cardiac surgeons. There's a lot of overlap between patients who are being seen for cardiac conditions, so come in for their cabbage and then turns out, you know what, you're 64, you have a 50-pack year smoking history, and you were smoking up until the day of your heart attack, you know, you'd probably benefit from lung cancer screening. So there's definitely populations of patients who should be an easy fit into the program. And it's a matter of educating, because they're also going to be there. You know, these are people that usually are going to have some sort of regular routine follow-up. So when you come back for, you know, your not necessarily your post-op, but, you know, your 6-month checkup, you can go ahead and get a lung cancer screening CT. So I think there's definitely opportunity to access more or get more patients into the program. But yes, primarily we're looking at primary care and pulmonologists. And like Debbie said, a lot of the pulmonologists will order their own scans, do all their own follow-up, but we do have a handful that, you know, we read their notes and they'll say, you know, I'm prescribing this for their COPD, I'm recommending pulmonary rehab, and they know they need to go follow up with Debbie to get their lung cancer screening CT next month. So they're happy for us to do that. And a big part of that is the way we communicate. We have a pretty collegial relationship with these providers. We can let them know what's going on pretty easily with their patients.
Well, and I think I would add to that, we are fortunate, we have a multidisciplinary conference, 3 Thursdays out of the month. And we have interventional pulmonologists, thoracic surgeons, and a radiologist there. So we actually look at all of the lung cancer CTs that are done across the system, whether or not we've ordered them through our program. And so if any CT comes back with a 3 or a 4 or a 0, so a 0, 3, or 4, anything that needs follow-up, even though they're not our patients, they're all reviewed. And Hilary and I send a written form to those providers to let them know, especially if their patients haven't had their CT scans ordered for follow-up, to make sure that those patients don't fall through the cracks. So that affords that opportunity to have that interface with a number of providers to say, you know, we're here. If you'd rather send them to us, we'll be happy to do it, which we've been, I think, seeing more and more of those come through as well.
And do you all have a strategy for educating primary care or suggestions on what others can do? I know that's a huge issue just in general, the awareness in primary care and referring patients for screening. But do you all do anything there to reach out to your primary care providers?
Dr. Tong has physically gone to several of our Duke primary care locations around the state, but I mean primarily around the Triangle area. I have spoken virtually a couple of times to family practice residents who are seeing a lot of patients in clinic, to let them know about lung cancer screening and how to refer. So it's really a spreading the word, and then hoping that will continue, you know, to spread. But yeah, Dr. Tong has gone physically to several locations, and Debbie and I have done some outreach via virtual meetings and updates with medical residents. I mean, there could be more to do, but you know, and like I said, Dr. Tong's been talking with the cardiac surgeons to talk about trying to get more patients into the program that are eligible.
Well, I definitely think it's going to take all of us to try to spread that awareness. I wanted to ask also, what are the guidelines that you all use for who should be screened? And do you take into consideration radon or family history or anything like that? And what do you do when you get those patients? Because you probably still get them.
We follow the guidelines that are currently covered, which are between the ages of 50 and 78 years old. I mean, I know it goes up to 80, but Medicare is only going to cover through age 78. And the majority of the patients are obviously within that age range. They have to be current smokers or recently quit within the last 15 years, because that guideline still holds with a 20-pack year history. Those are what we follow for this. If they are outside the guidelines, we cannot screen. We do reach out to their primary care. So if there is a concern outside of screening, you know, different ways to code CT scans, certainly you can order a CT chest with lower radiation, just as a low low radiation scan. But and if they come with radon, we did have somebody a couple weeks ago, I think, that had called that never smoked but had all these other environmental risks. And if they want to pay out of pocket, it's certainly an option, but insurance won't cover it for under a screening protocol. So we have
Yeah.
not been able to do any that I'm aware of. Are you,
Right.
Hilary?
No, we can't screen them. I mean, one of the toughest cases I had was a woman who had called and you know, again, no personal history of smoking, but mother had died of lung cancer, sister was currently battling lung cancer, and she said, you know, everybody in my house smoked my whole life. I have so much secondhand exposure. I have this positive family history, and I had to keep telling her, well, you know, we can't screen you under lung cancer screening. You should talk to your primary care provider about risk and see if they can order. I mean, it's tricky, right? I mean, the primary care doctors are going to have a hard time ordering a scan unless they have symptoms. But yeah, we have to tell them we can't do it. So I can guide and make recommendations, but we cannot order, even if they say, and they will, I'll pay out of pocket to have it done. I say that's great, but we can't do it through the lung cancer screening program at Duke.
And so would you do it if they were willing to pay out of pocket, or they would do it through their primary care?
Primary care, because they don't qualify for screening. They don't meet criteria for screening based on the United States Preventative Services Task Force recommendations.
And it's unfortunate because honestly, when we think about this, since 20% of patients with lung cancer don't smoke, they need to change the guidelines, not just get rid of that 15-year qualifier, but
Yep.
just anyone. Just like we do mammography. Like we don't tell women with breast that if you don't have breast cancer in the family, you can't get a mammogram. I mean, clearly we all know this should be for everybody.
Well, and so let me ask you about the patients. What kind of barriers do they encounter when they're going for lung cancer screening? What are things that you hear about? I'm thinking of cost and even, you know, access, things like that. But then do you kind of help them navigate through those challenges, or how does that work?
So so barriers are cost. So just the cost of, you know, they have to meet criteria for screening. Usually once they hit Medicare, some people, they can get through with a scan without having to pay much. If they don't have Medicare, even if their insurance covers lung cancer, you know, they meet criteria for screening, the insurance company will cover it, they still have a copay, you know, which can be really expensive, or they have to meet a deductible, which can be really expensive. And the insurance companies are different. And I try when I get these questions, you know, I start out by saying I'm a nurse practitioner. I don't know all the ins and outs of your, you know, every insurance company, because I don't, although I've learned more for sure. And so I encourage them to call their insurance company to discuss it. And certainly Debbie and I have gone to bat by doing these peer-to-peers with the insurance companies to say these patients meet criteria, but we can't do anything about $150 copay for a scan. And $150 is, you know, a pretty big barrier for a lot of folks. Then there is the transportation. So some people don't have anybody to bring them, or in order to bring them, they, you know, son has to take a half a day off from work, and they're really hesitant to ask them to do that. You know, on the other hand, a nice benefit that we have through Duke is if we can do telemedicine, they don't have to leave their home. And as long as they've got some sort, even if they don't have good internet coverage, if we can do telemedicine if they've got a decent cell coverage through, you know, just through a telemedicine text message that then they can log into, and we can do it that way. So we have, sometimes it's like pulling teeth to get it to work, but we usually can do that. But we can't, you know, we can't take the scanner to their house yet. So they do have to get to the site of the scan. Now we have, I think Debbie and I, we figured out about 5 locations. So we have Duke Raleigh, and then we have Duke in Durham, and there's like 3 separate spots at Duke in Durham. We have one in, which is Arrington, which is in Morrisville. We have Cary Parkway, and we have Heritage, which is in Wake Forest. So, you know, but if you're somebody who lives in Roxborough, and you're 30 minutes away from Big Duke. We don't have a scanner yet that we can use at Duke Regional, which a lot of our patients would really like. A, because it's less traveling miles to get to, and B, because a lot of patients don't want to have to navigate that parking deck, pay to park in the parking deck, or pay valet. That is really overwhelming for a lot of people. So, I will try to say you might have to drive a little bit further to get to Arrington, but then you park in a parking lot and you walk in and get your scan and get out, and they'll do that. So they're these little things that we think are little, or I think are little, but these are huge issues for folks. So we really try, just telling somebody, you went to Duke Raleigh last year, but turns out you're a lot closer to the Wake Forest site. That is like a huge change, and that is something that will motivate them to come back. But I think that's financial, traveling, and then fear. I mean, they're worried about what that scan might show. Again, most of them still will go through with it, but I think that does give some people pause, what news we're going to give them when we go over the results of the scan. Does that sound about right, Debbie?
Yeah, you're right on. I don't have anything to add to that. It's the cost barrier is huge.
And how do you work with getting them back for annual screening? Do you schedule that at the appointment that you have? Do they have to call back to schedule it? How do you get that set up? And do you tell them ahead of time this is an annual screening to prepare them for that?
So when we go over the scan, we show them the images and go through everything. And then at the very end, I always say to them, it's recommended that we do this again. Are you up for doing this again? I think it'd be a great idea. And I have to say 99% really have said, yeah, I'll come back. And I just double check to see the time and place where they were scheduled and ask if that worked for them. If not, do they prefer a weekend or whatever, trying to make it as easy as possible for them. And then we go ahead and get it scheduled a year in advance and remind them that if they're sick or they want to travel or something comes up, they need to reschedule. They can either call our scheduler, which is still a bit of a challenge for us, or they can reach back out by their MyChart to us individually, and then I'll just get it to the people who need to get it rescheduled for them. So it's a pretty, you build that rapport with people, and if they trust you, and so far it's been working really well this year.
Yeah, I agree. I don't think you can underestimate the value of rapport with your patients. And, Debbie and I have, between the two of us, have, over 50 years of nursing experience. And so I'll, proudly say, I think that having that ability to really talk with people, meet them where they are, acknowledge their barriers, their potential barriers and their fears, and do everything we can to make it as easy and convenient. And that is often, I've got 2 patients this week that said, I can't come during the week. I just can't, between taking care of my husband and my work schedule. And so we have a couple of scanners that are open on the weekends, like Debbie said. And so getting them in at 7 o'clock on a Saturday morning, so they're back home by 8 o'clock or 8:30, is very attractive to people. And then also giving them that expectation when you first meet them. So when we have that initial visit, to say, the first thing I say is, we only do this initial visit the first time before you get your first scan. So you have a good sense of why we're doing this, and you can make sure that this is something you want to do. But if you decide to do it, you need to understand that lung cancer screening only works if you come back and see us next year. And I will give the example, you don't get a mammogram when you turn 50. And if that's fine, you say, great, I never have to do that again. And then you can see them nodding like, okay, I get it. And reassuring them that it's easier than a mammogram. And again, we'll do everything we can to make it as easy and convenient for you. And I think that Debbie and I do have pretty good rates of keeping our patients and having them come back. And the last thing I'll add about that is, there are some people that, we don't do a lot of smoking cessation counseling. I always tell my patients, I work in the world of lung cancer, and smoking currently is the #1 risk factor for lung cancer. So I encourage all of my patients to quit. But whether you quit or not, I want you to come back and see us next year. I never want a patient to say, I don't want to go back and see her because she's going to give me a hard time about my smoking. And I think acknowledging that, saying that out loud to them, makes a difference too.
Yeah, there's no judgment. that's a decision they need to make on their own. We're supportive, but never judgy.
That's great. And I think it's so important and just shows the success of your program, having both of you there and navigating and getting to know the patient and kind of walking them through that journey. I think that's so special.